Hello, hello, welcome everybody. I'll give people a minute or two to get settled in. Thank you so much for being here at our webinar today. So I am Corey Linneman. I am the president of the Parenting and Families Special Interest Group for ABCT this year. And we are so excited to bring you a very interesting talk that is targeted at providers today. So helping us take our therapy game and our behavioral mindset to the next level, we have Dr. Matthew Edelstein, who is the director of the Brief Treatment Clinic at the Kennedy Krieger Institute and also an assistant professor in the Johns Hopkins University School of Medicine. And then we also have Dr. Robin Hahn, who is a psychologist at the Early Childhood Behavioral Health Program at Children's National Hospital. So I am going to get out of the way. Oh my gosh, Robin, I forgot that you're also an assistant professor now at George Washington's University School of Medicine and Health Sciences. Very important. Can't leave that off. Okay, now I will get out of the way and let these two take over and give us this interesting talk that I'm excited to see.
Thank you, Corey, and no worries. Yes, hi everyone. Thanks so much for taking time out of your day, your lunch hour, or this break to join us. We've titled our talk, Programming Your Clinical GPS, a guide to navigating treatment decisions when working with children with disruptive behaviors. And the hope is that after this presentation, you'll find the information helpful, whether you're a new clinician or a seasoned clinician, so long as the work that you do revolves around treating child problem behavior. So I'm going to turn it over to Matt.
Hey everyone, thanks for welcoming us here today. So we're gonna try to tackle quite a few things in our hour together, a little bit less. So hopefully these learning objectives are of interest to you. First, we want to talk about these four domains of our work: feasibility, acceptability, efficiency, and effectiveness. Why they're important and how they impact us as clinicians. Next, we want to think about decision points in treatment where information that we're getting in the moment might tell us to perhaps take a different tack or to modify our procedures in a way that we might not have expected at the onset. And then finally, how do we collect those data? How do we make sure that we're asking the right questions in order to make sure that we're designing and proceeding with our intervention in a way that's helpful? Okay, so I'll note that Robin has very kindly offered to do the slides for me. So if there's a delay, we're still working on kind of our timing here, our nonverbal behavior. So all right, so treatment for the outliers. Most of the work that we do, all of us as clinicians, is evidence-based. And evidence-based work is evidence-based because it works for the majority of children. That's how the evidence base is collected. As we continue to expand the reach of this work and want to reach new patients with new types of problems, the majority continues, but the pool of outliers, the pool of individuals who are not captured by the evidence base may grow. And what's hard for us is we don't always know who these outliers, who these kids are who might be non-responders to treatment are at the onset of our work. So that requires perhaps some modification or at least some acknowledgement that some of this work might not work for everyone. So before I go on and continue, I want to just highlight my own background because I want to recognize that I'm approaching this topic from my own perspective. So I'm a duly licensed clinical psychologist and behavior analyst. So I have my roles are I see patients, I train, I do research, but my approach is really based in behaviorism, and I suspect that many people in this call would identify with that. So implicit into that idea is some of these other components here. One is that while we consider diagnostics, the diagnosis that a presenting case has, a child has when they come into our service, we care about those things. They're essential, but it's not sufficient towards our treatment goals, that there's more information that we need in order to do our work well. The other perspective that I take in my work is that behavior is lawful, it happens predictably if we had enough data and enough time to collect all of the information about the context and the antecedents and the consequences, that behavior would be predictable, and that behavior involves everything that a person does and says. Finally, the perspective that I'm offering today is that challenging behaviors occur because of deficits in two key domains. That there's either a skill deficit, that the child doesn't know how to meet an expectation, that there's a motivation deficit, that they might know how, but they choose not to, or that both of those things are happening at the same time. Okay, so just to make sure we're all on the same page when we talk about challenging behavior, because that's sort of the basis for this discussion, I want to highlight what challenging behavior is from this perspective. Challenging behavior is based in an unmet need and serves a function. When I say function, I mean that it's working in some way for the child. So if we look at this graphic on the far left here, we sort of have this box that says unmet need, and the behavior might be this little boy crying or having some what we might call challenging behaviors. So based in this perspective, we would say that this tantrum or this crying episode is happening to serve a function. And that function could be a variety of different things. It could be serving to help the child get out of something or avoid something. It could be serving to help the child get access to attention or access to someone that they want, or it could be serving to help the child get access to items or activities. We call those different functions escape, attention, and tangible. And we have to acknowledge that these different functions are not happening in isolation, that in fact they could all be happening all at the same time. There could be escape and attention functions, tangible and attention functions. But if we think about it this way, often we're left thinking, well, what is the function? Why is this behavior happening? How might it be working for the child? So, and the emphasis on all of this is that challenging behavior does work. That as human beings, we don't do things that don't work. And so our choices, our responses are based in a history of what's worked in the past. And so we're just sort of making choices. We're engaging in behavior that we expect to work in the future. So again, if we look at this diagram, we sort of see from left to right the progression. On the one hand, the child might start, and I'm not sure why my child has blue eyes, but let's just say that's what we would expect for this child. So he has blue eyes. That's not his problem behavior, though. He has an unmet need. He wants candy. And so we might even call that the antecedent, right? That's a word that's probably familiar to folks here. Then we look at the behavior. Oftentimes as clinicians, the thing that comes to us through the caregivers of our patients is that this is the problem. The problem is that our child is crying and screaming. And as behaviorally oriented folks, we know that every problem brings with it a context. So we're thinking about what happens before, and we're thinking about the behavior that's happening. If the behavior works, then the behavior turns off, right? If I am crying to get candy and I get my candy, and it looks like he has cotton candy on his thumb, which is pretty neat. It's worked, and so now he doesn't need to cry anymore because the behavior has netted the outcome that he was looking for. If it doesn't work, well, he'll either persist in that behavior or perhaps escalate to other behaviors that he might expect to work better. What I think is important to highlight here is that there's a multi-directionality to this behavior, right? So as a child, I can't facilitate the outcome that I want, then I can't necessarily get the cotton candy myself. I'm dependent on my caregivers for that outcome. And so caregivers are also experiencing their own reinforcement contingencies, their own ABCs as part of this. And so if I'm a caregiver and I'm giving in perhaps, and I'm giving the candy, well, perhaps I'm escaping or avoiding my own distress of my child's distress. So with that as a context, I want to shift to sort of the more deliberate and more purposeful part of this discussion, which is what are our goals? And I want to highlight that oftentimes caregivers come in with their own goals. And so a caregiver might say something like, well, this challenging behavior, this tantrum is unmanageable, and so I need the behavior to be reduced to a more manageable level. Or they might say, I'm really resenting my child. I'm really frustrated with this interaction that I'm experiencing every night at bedtime. And so I want to improve the relationship with my child. While those goals are certainly important, those are the caregiver goals. Those are the family goals. And they might actually be different from the goals that we have for the nature of our work. Certainly we want to meet those caregiver goals, but we sort of come in informed by our own objectives in how to do this work well. And so I sort of I teased some of the answers to these questions, but if anyone wants to volunteer what their goals as a clinician might be, certainly you're welcome to do that in the chat. But what might be an example of clinician goals for a service? Because we don't have a ton of time, I'll leave you thinking about that, but I won't leave you thinking too long. Okay, hold on. Psychoed to caregivers.
Mm-hmm.
We want to educate, right? We are teachers in addition to therapists. I like that. That's really helpful. Improve the quality of life, right? So not all that separate from some of the things the caregivers are bringing, providing feedback on skills, making sure that the things that the family is doing are happening in a procedurally correct way. Decrease the need for more therapy. I like that. Build confidence, build positive interactions. This is fantastic. I was worried that folks would be too shy to participate, and my worry is assuaged. So thank you. That's all. Those are all absolutely goals that the clinician has. But I want to think even bigger picture than that. Robin? So I think that our goals broadly, and these goals speak to some of what you all highlighted. Our goals are to create an intervention, to use the training that we have to address these 4 domains. So first, we want to make sure that our treatment is acceptable. We want to make sure that we're creating an intervention, we're programming an intervention that is in accordance with the family values. And we do that through a lot of the things that you mentioned: psychoeducation, building confidence, all of those pieces. We want to make sure that the treatment is feasible, right? So a lot of times, particularly in my context, we do things that parents might feel are really hard. And so if we can just do it in our context and the family can't do it in theirs, we wonder what good is all the work and effort that we're putting in. So that this work has to be feasible. The family has to be able to do it. Efficiency is a really important goal. We want to make sure that we are achieving an outcome as quickly as possible with as few delays as is practically possible. And that's because our families are in distress, right? Our parents are coming in recognizing that there's something not working for them. And as you talk about quality of life, oftentimes our families have a pretty poor quality of life given some of the problems that they're dealing with. So it's kind and compassionate to reach those outcomes as efficiently as possible. And finally, effective, right? We want to make sure that not only are we doing these things, but we're doing them well in a way that translates beyond our clinical setting, beyond our therapy environment. So there's a variety of different ways that we do this, and so I'm creating some categories here in order to highlight some differences between these different approaches to our work. And we may use these approaches interchangeably, right? So one clinician might not just do one thing. We probably borrow from each domain. So on the one hand are the treatment manuals, right? So manuals provide these step-by-step instructions for how to carry out an intervention. They're systematic, right? They sort of describe the how. Here's how what needs to be done. Here's how to do it. I think that manuals in a variety of ways are different from protocols. And so protocols are not step by step in that same way. Instead, protocols are a set of guidelines for how to perform a series of procedures. It sort of thinks about where the essential steps are and how do we iterate from step to step? How do we use information to guide us through these series of procedures? And so in that way, protocols describe a little bit more about the what rather than the how. And finally, we have what I like to call a la carte treatment strategies. And so what I mean by that is sort of we have this immense knowledge base as therapists and clinicians, and so we sort of pull from these different strategies, all based in the evidence, in order to use what we think is important or necessary in the moment. And so we're in that way, we're sort of combining individual needs with our understanding of best practice. So I have taken a leap here, and I've assigned some grades to these different types of approaches, and these are opinions are my own. Feel free to disagree. We can talk about it, and I don't know that I will argue too much, but I think I'm doing this more as a way to just sort of start to think about where the strengths and perhaps weaknesses are of different approaches. So manuals, in order to be a manual, you need to have a strong evidence base. But manuals tend to focus a little bit more on the procedures and whether they could be implemented by a wide variety of people and sort of what the outcomes are at the group level. So what I've done here is I've kind of given them a grade, manuals a grade of that they're feasible because they're sort of targeting a group level. They're effective because groups are generally showing that there's good outcomes from the implementation of the manuals. But manuals are not always designed to be efficient. Some are, but not always. And sometimes individual differences can sap the efficiency of a manual. And finally, there's an acceptability, perhaps maybe that will score manuals a little bit lower just because manuals are designed to be implemented writ large, and the individual clinician, it's up to them to sort of figure out how to modify a manual in accordance with the family's needs. So then I'm going to skip one category in order to sort of achieve a dramatic effect here, and we're going to jump to the a la carte strategies, right? So a la carte strategies tend to be the most acceptable to families because we're really pulling and plugging in specific things that our families are asking for. But however, with that sort of with that approach, there might be some downstream negative effects of using a la carte strategies. So as we're sort of pulling different things that we think are useful, we might be sapping the efficiency of our intervention. We might inadvertently be adding time to an intervention because we're perhaps thinking about what's happening in the moment and not how all of these pieces come together in order to facilitate a quick outcome. And then effectiveness, right? Going to go back real fast. The effectiveness piece is also important because at the individual level, we might not know how all of these pieces come together to promote a good outcome, right? And an a la carte approach suggests that we've not studied this combination of intervention components, and so we might not know how effective they are. Finally, we have the protocol piece where protocols are meant to combine this sort of conceptually systematic approach with individualization, right? We're thinking about how to take information and use it based on some systematic understanding of the order of how things need to be introduced. And I think that protocols ensure some equal access to successful outcomes for the folks who haven't been studied in group design, and in some sense can help facilitate outcomes, more even outcomes across all kinds of patients and populations. So for individuals who might not quite understand the difference or even disagree with the difference, I want to just sort of use an analogy to highlight what I think a protocol is and what it isn't. And so I'm going to use this GPS metaphor, which sort of brings us through all of our conversation today to highlight what a protocol is. So a protocol is fundamentally iterative, right? So each phase in the trajectory is informed by information that's obtained in the previous phase. So if we think about this in steps, right? So if we're using our GPS, thank goodness for Waze, we might start by plugging in our current location and where we're going. And so what that means is in the clinical sense, we're sort of trying to understand the mechanisms that are underlying the presenting issue. Then once we've plugged that in, sometimes it gives us options for which route to take. And so we might have to decide that which route makes the most sense. And so the clinical version of that analogy is really using a conceptually systematic approach based on the results of the assessment. In that sense, the assessment is telling us which route to take. And in your GPS, it might say, this one is with tolls and this one, it adds a little bit of time and whatever else. Finally, there's the on the ground information, right? So you might, as you're driving, you might find that there's an accident, and your GPS might reroute you to another route that might get you to your destination at the same time, right? With the same amount of time spent. And so then that clinical side of it is the proceeding at a pace that's dictated by the individual's response to treatment. In some sense, that we don't move to the next step until we feel that a particular skill has been learned. So in my practice, what that sort of looks like more clearly is we'd start by assessing the why. Remember that we talked about this idea of function, that each child behavior might serve a function, and so we need to understand the why behind the behavior in order to program our GPS to know what to do next, to know what route to take. Then we need to teach skills. We need to teach skills to the child and to the caregiver, because those are the necessary steps towards achieving an outcome, to arriving at our destination. We want to make sure that we are always considering the application in the real world. How do we make sure that in our teaching context, we're thinking enough about beyond the walls of our setting to help caregivers understand how this works? And finally, we're constantly tracking our progress. And if a parent comes in and tells us that I want to reduce my child's challenging behavior, well, then that needs to be what we're taking progress data on, right? Because that's going to be the indicator as to whether or not we're reaching our caregivers' goals.
And Matt has given such a nice, conceptual foundation for, the difference between manual and protocol, the importance of function. And sort of as a clinician, you might be asking yourself, so what? So what does this mean for me as a clinician? How should this inform my work, if at all? And so before I answer that question, I want to backtrack a little bit and tell you a little bit about my training trajectory, because currently I work at an outpatient clinic in Washington, D.C., but previously I was a graduate student in a PCIT lab and doing a lot of PCIT throughout all of my years at school. And I didn't realize or appreciate at the time, but a lot of these cases were really handpicked for a new trainee. And so they really fit the mold of what your traditional PCIT case should look like. And when I learned the manual, it worked beautifully. I didn't really have many road bumps, and when I did, they could easily be solved by asking a supervisor. And so now that I'm working in an outpatient setting and just kind of taking families off a very long wait list, I'm realizing that a lot of these cases are a lot more complex than I had in grad school. Maybe there's neurodiversity, maybe there isn't. Maybe there are cultural values that make it really difficult for a family to accept the way this manual is written. And so that got me really thinking about some of those goals that Matt outlined earlier, the feasibility of a treatment, the acceptability, the effectiveness, and efficiency. So I'm going to talk about those. I'm going to bring them up again in a future slide, but I want to spend some time talking about what I call pivot points. And Matt referred to these as kind of these road bumps or accidents that you might see on the road. And these are basically just points in treatment where you might be asking yourself, okay, this isn't going as smoothly as it normally does for me. Do I stay the course? Should I pivot? And even if I do pivot, what do I pivot to? And how do I know how to pivot? And so one such point might be one such pivot point might be when you are implementing a manual that you know is tried and true, but it seems to be difficult to implement in the current setting. And so maybe this could be a case where the disruptive behaviors that you're encountering are a little more severe than what you're accustomed to, and maybe your clinic isn't set up to withstand those behaviors, or maybe things are working really well within the treatment space, but when the family goes home, it's really hard to implement in that home setting. And so you might be thinking to yourself at this point, okay, maybe this is a time to refer the patient out. Maybe this is something your supervisor has said to you in the past or director has said to you. But I want to offer an alternative perspective. And that might be, what if this is the only context in which this family can receive care? Or what if this family has been waiting on your wait list for over a year, and now you're saying, sorry, you're going to have to wait on a different wait list for a really long time? And so that might be an alternative perspective that might make you think, is there a way to pivot? A second pivot point might be when a family seems reluctant or hesitant to continue with treatment. Maybe the family is more on that permissive side of parenting, or maybe they're uncomfortable with some of the strategies or discipline approaches outlined in a standard manual. Maybe for whatever reason, there are cultural values that don't align with what you are asking them to do. And so you might be thinking to yourself, okay, maybe I just need a stronger sales pitch. Maybe I just need to convince them. I'm going to do a parent only session. I'm going to really try to get them to buy in. But an alternative perspective to that is, what if continuing with treatment as is means you lose the family? They drop out. You lose buy-in from the family. And I think that is a worthy question to ask, especially when it comes to that acceptability piece. And then a third pivot point might be when patient symptoms don't seem to be improving or worsening. And one thing that you might say to yourself is, this is just an extinction burst. I need to just, keep on keeping on, and they'll get it eventually. And that might be true, but an alternative perspective is, does the short-term impact justify the long-term gains? So is the pain in this moment worth what you think will yield, like greater behavioral improvement? And sometimes riding out an extinction burst is not feasible for a family, or might not even be possible. And so it's a question worth asking for sure. And then a last pivot point I'll talk about is when patient symptoms, they are getting better, but they're getting better at a slower than desired rate. So it's taking a long time. And one thing you might say to yourself is, just trust the process. I've had this said to me too, like, just trust the process, trust the manual. It's been researched, it's evidence-based. But something that often like I hear in the back of my head is there a more efficient way to get symptom reduction? Is there something that we can do to speed this up? Because at the end of the day, I'm not going home with this child. This family is going home with this child. And so they are living in distress. They're the ones getting hit, punched, kicked. And is it ethical to continue on in this approach if there is a more efficient, maybe faster way to get those gains? So this brings us back to the goals for treatment that Matt outlined earlier. And I put these in question form because I think about these concepts a lot, not just as a provider, but as a parent who's been on the receiving end of behavioral therapy for her kids who have disruptive behaviors. And so one of those pillars is feasibility. Can the intervention be carried out successfully in the current setting, whether that's your clinic, your agency, or in the family's home? Is acceptability? So does the family find the intervention to be in line with their values, beliefs, perceptions, and attitudes related to parenting? And then effectiveness, does the treatment work? In other words, does it actually improve patient outcomes? And like Matt said, if the thing that the family wants is to improve child behavior, are you kind of measuring those outcomes and using that to gauge whether something's effective? And then efficiency, is the treatment working in the most economical way possible, or that you know how? So I pose those questions to this group of clinicians, and then I argue that when you hit one of these pivot points or these road bumps, it's a really good time to kind of step back and reassess. And that might mean adding some time to your treatment trajectory, but I think it's a worthwhile investment. And so if you think about what a typical assessment battery looks like for child problem behavior, it usually involves some sort of interview with the caregiver, some sort of structured or informal observation of the child or parent-child dyad. And then usually we give some questionnaires like the ECB or the BASC, and there's a lot of focus on topography, so what the problem behavior looks like, and then the frequency of the problem behavior. And that is important, but we argue that that's just the beginning. It's not the topography is not the be all end all. And the reason is because topography can and often does change. I don't know if you've ever felt like this as a clinician, but sometimes I feel like when I focus on what the behavior looks like, I feel like I'm chasing a moving target, or I feel like I'm getting derailed by the parent. Like they're giving me a problem of the week, and I'm like, okay, let's work on this, and then the next week it's something different. So I think one helpful way to think about it is going back to what Matt said earlier, which is focusing on the function, the underlying mechanism, or the why a child is exhibiting a problem behavior or a class of problem behaviors, and then taking time to reassess, to determine, all right, what are the probable functions of this child's problem behavior? And then how can we use that knowledge to guide our treatment moving forward? Even if that means switching things up in a manual that we know is tried and true for the majority of kids we work with. So here are some questions that I literally pulled from an article that Matt and his colleagues wrote on a function-informed interview. And these questions can be asked to caregivers to really get at what the possible functions of a behavior are. And so looking at antecedents, what events typically trigger the target behavior? Another way you might ask that is, how could you turn the target behavior on? How could you make me see this behavior right now? Like, what would you have to do? Consequences, what happens immediately after the target behavior occurs? Or another way to say that is, how might the child's problem behavior be working in that child's favor? And then said another way, how could you turn the target behavior off? What would you have to do to get your kiddo to stop engaging in that behavior? And it's interesting because we often ask these questions in an intake, but we don't always use it to individualize treatment or inform treatment. It's just kind of more data gathering or to better understand problem behavior, but we don't actually use it to inform our next steps. And so some key questions that I hope that we can ask as clinicians. One question is, how could the intervention be modified to enhance and capitalize on these 4 pillars that we talked about? Another question, does the treatment component that we're using actually match the child's behavioral function? And if the answer is no, then what other treatment components would yield a better match? Another point is, what skills would the parent benefit from learning, and how can we teach the parent these? And a lot of our work might be would fall into that realm of behavioral parent training, and we're really good about this, identifying the specific skills that a parent would need to benefit from. One thing maybe that we don't always look at is the skills that a child could benefit from learning. Even a child as young as 2 or 3, are there skills that we could teach the child, and how would we go about teaching those things? And then lastly, which data will I use to monitor progress and determine that we've successfully met our treatment goals? And so I'm going to really quickly go through a case example, and instead of focusing so much on the individual descriptors of the child and the family, I'm just going to focus more on the intervention and the treatment trajectory. So this was a 5-year-old boy who came into our clinic with a single mom. The presenting problem was tantrums, aggression. And so in my head, I just went, okay, PCIT, I'm familiar with it. He's in the age range. The presenting problems, I'll check the box in terms of what PCIT could target. And so to me, it was a no-brainer. The family strengths that I quickly identified were that mom was super motivated and she was really diligent about home practice. So I knew like this is going to be a parent who's going to acquire the skills very quickly. Um, the unexpected road bump during, for those familiar with PCIT, the first phase of treatment is child-directed interaction. It's teaching the parent about positive attending and also withdrawing attention for inappropriate behavior. And the parent really struggled to engage the kiddo in what you might think of as traditional CDI play, CDI activities. So, like magnet tiles and drawing and things like that, the kiddo really had no interest in. He liked to play hide and seek. He would do like these break dancing competitions with his mom. And so, it was really hard to kind of teach a parent to use the skills when they're like dancing. And in my head, I was like, oh, this is not following the manual. But it's also, I feel like I'm also wasting a lot of time trying to like reel this kid in to enjoy these activities that he clearly could care less about. Um, so what is a clinician to do in this situation? A question that I ask myself is how could I modify the intervention to enhance feasibility, acceptability, efficiency, and effectiveness? Um, so maybe one way is to choose play activities that the child finds more reinforcing. And maybe I can still coach the caregiver to use positive attending or use these skills and make her presence more reinforcing by choosing activities that the kiddo genuinely enjoys. Um, what skills would the parent benefit from learning? So yes, there are specific skills that we teach parents in PCIT, like how to give a labeled praise or how to reflect a child's statement back to them. And yes, those are great ways to show positive attention. But at the end of the day, isn't what I really want to teach the parent just differential reinforcement? Can you, in the presence of problem behavior, withdraw whatever the child finds reinforcing, and in the absence of problem behavior, so in the presence of appropriate behavior, can you give them that access, give them full access to the things they find enjoyable? And then teaching a parent to understand what motivates the child, I think is a huge takeaway for a family and something that can really help a family even after they've graduated from treatment and they still inevitably run into some challenging behavior. Um, and then another question that you might ask yourself is which data will I use to monitor progress and determine completion of goals? And maybe what I really need to see and is the parent's ability to dial up their attention and access to preferred activities like breakdancing competitions when the child has appropriate behavior, and then really dial it down when the child demonstrates inappropriate behavior. A couple other road bumps I ran into in the second phase of treatment in PCIT, where we focus on equipping a parent with discipline strategies, was that timeouts were lasting a really long time. And usually, we all have really good stamina for, outbursts and tantrums, but you hope to see a decrease in the length the child is in timeout over time. But for this kiddo, we weren't quite seeing that, especially in the home setting. There was a lot of physical aggression on the way to timeout while the parent was doing her best to carry this kiddo to a chair. And the parent just seemed like they were going to be done with me in a second if I didn't pivot. And there were out times where the kiddo loved going out to a timeout room and he loved getting out of the chair and he was laughing and he thought there were moments that were clearly enjoyable for him. And so again, some questions I asked myself. Does the treatment component match the child's behavioral function? I did take a step back and decided to do some reassessment and found that a lot of this kiddo's behavior was escape maintained. And so using a timeout for a problem behavior that's escape maintained was not the most effective and also definitely not efficient, was as you can see. And then could was there kind of an alternative strategy that I could use to reduce opportunities to actually escape those parental demands that were contributing to or triggering problem behavior. Some questions I asked myself: what skills could the child benefit from learning? How to comply quickly and without problem behavior. And that sounds so vague. So really breaking that down and teaching a child, what does without problem behavior actually look like? I'm talking, I want an inside voice. What does that look like? I want hands to yourself, safe body, and actually practicing those skills, not only in the context of like a timeout situation, but in the context of, enjoyable play with the parent, actually teaching them and labeling those skills. And then which data will I use to monitor progress? One of the things that I decided was I wanted to track the amount of time it took for a kiddo to comply with a parental demand. And then I also wanted to track, was the child complying with problem behavior or without? And I wanted to make sure that the parent and I were on the same page about what that looked like. And so I'm going to turn it over to Matt. I know that I blew through that case study, but I hope that it kind of showed you a way of thinking about things when road bumps come your way.
Okay. So, when we're confronted with these road bumps, we sort of have two options, right? Or let me say, we have two options from the onset. We can begin with our standard treatment approach. We can sort of take the approach that Robin suggested in one of her examples, where she sort of says all the stars align to point to this type of intervention, but we could create a safety net for outliers and sort of say, where are the points where I'm going to choose to reevaluate and say that this might not be working? So even sort of being open to consider this reassessment process could be that safety net. Another alternative is more proactive approach to say, you know what, I don't necessarily want to sort of fail into a different approach or fail into reassessment, particularly given that I'm concerned with efficiency and effectiveness, that some families, if they feel like they're going to have to start again, might be discouraged, not just for my own care, but in the utility of behavior therapy more generally. So instead, maybe I use this sort of iterative protocolized approach. So I'm thinking about my steps before I make them, rather than having to go backwards and do this reassessment in the presence of poorer outcomes.
And then we have some time that we're going to leave for questions. But one of the things that Matt and I are working on are trying to create a protocol or kind of a problem-solving guide for clinicians who are very familiar with parent-child interaction therapy, but for those times where you run into these outliers and you might need like a decision tree or a roadmap or questions to sort of guide you along the way. So we're excited to be working on it and hopefully get that out soon. But yeah, love to leave time for questions. You can throw them in the chat. You can unmute, whatever you'd like. And here are our email addresses too to reach out to us at a future time as well. So I can read this question, the first question out loud. What did you do to reduce opportunities for escape from the parent command? So I really pivoted. Yeah, but we decided not to do a timeout. And so what we did was the parent was already very familiar with um, effective commands and delivery of effective commands and follow through. So we capitalized on that. And instead of having a timeout procedure, we essentially just had the child be in a state of like highly reinforcing activities and a ton of positive attention. So essentially special time, but with these activities that we know he loves. this is very non-traditional, but like being on his iPad, he had the option, the iPad was in the room. There was music to play from the iPad so he could do his breakdancing. And we allowed him to play hide and seek. He loved to hide in the timeout room. So we allowed all of that to happen. Then when it was time for the parent to give a demand, we had the parent issue the command, and then we basically stopped all of those activities and access to all of those activities and reduced attention until the child complied. And I know that sounds very simplistic, but and difficult because in some situations there was a lot of problem behavior as we were waiting the kiddo out. But I think what has been helpful, and Matt has really walked me through some of this, is that when for a kiddo that has a lot of escape maintain problem behavior, when the demand is on the table and you continue to keep it on the table, it really reduces the opportunities that a child can have to escape. And a timeout chair, it might not seem like it, is an avenue of escape, even temporary escape from a parental demand. So yeah, I don't really want to put on my shoes or do this worksheet. So I'll go sit on that chair and then, oh, I'm gonna hop off this chair and go into this room because you seem to get really like aggravated by it. And this is more fun than doing the worksheet. And so what we found, which was effective, was that when we just placed the demand and we reduced all those activities, we used the first then statement, first effective command, then play, or then iPad, or then whatever. And then over time, the child realized that I could tantrum in this room and I'm still gonna have to do the thing. Yeah, sorry, and I want to skip through questions. Oh, Matt, thanks for posting the DOI. How do you I'll go to Kara's question. Oh no, hold on. Oh, sorry, I'll go to Juliana's question. How did you deal with aggression without timeout? And then Matt, maybe you can go and back and do the other two. But
Sure.
yeah, so that I think is a challenging consideration because if you don't have a timeout, you're not essentially wrangling the child. You're letting the child just be free in the room. And what that looks like is having some guidelines in place for the child. So, kind of like what you do in CDI, if you hit mommy, mommy will leave the room or mommy will step out. If you throw a toy, toys, if you throw your iPad, iPad goes away. And so there were times where the room was emptied of furniture and of people and of things, except for the thing that was the demand, related to the demand. But yeah, Matt, I'll have you go. Sorry. I feel like I could
Yeah,
go
so
on.
there's a lot of questions here that I think are incredibly useful around how to manage reactivity. And I think part of what we want to highlight about the use of this sort of systematic approach is that if we're rolling out skills very gradually for the child, they're building on skills that are previously learned at very low demand low demand points. So essentially what we want to do, we want to teach kids to tolerate the presence of demands incrementally rather than all at once. And so our work really focuses on thinking about breaking down the expectations into its components in order to minimize reactivity, right? So it's really a proactive or an antecedent-based approach. Our goal is to avoid having to figure out what to do with aggression by not evoking aggression. And so what we found is if we're able to sort of teach very incrementally in a similar way that they'll do in education, where before you need to learn to read, you learn the letters and you learn to pronounce them, and then you learn uppercase and lowercase. So by the time you get to reading, you've sort of built upon those foundations, and your reactivity may be lower because you have all of this history of success beforehand. So the emphasis is really on the proactive approach. I also like this question about telling a parent about extending treatment due to pivoting. I think what's implied there is that if you didn't pivot, that treatment would be shorter. But the idea behind the pivot is that we might recognize that we're not achieving the goals that we set to achieve on the outset. all of this is in the service of efficiency, right? So parents come into us in order to achieve an outcome, and we strive to get them to that outcome, whether it's reduction in problem behavior or whatever else. The only reason we would pivot is if we found evidence that our approach was not effective or not efficient. And so the rationale presented to a parent is, we actually have learned something about your child that will make us more successful, that will promote more generality outside of this treatment context. So most people do want an outcome that will travel with them beyond the teaching context.
Matt, there's a question above that says, how do you balance redirection of behaviors without giving too much attention to that behavior? For instance, safe hands in the context of hitting others. I thought maybe you could take a stab.
For sure. So remember that all of this is predicated on the idea that we've taught these skills outside of challenging behavior. So what Robin said, and is really important, is that if, safe hands and calm body and the language that you use is already receiving access to reinforcement, we've established a learning history for this child that we're not necessarily needing to give them any new information. Right. So we never want to teach new skills in the context of challenging behavior. Kids are not open to learning in that particular context. Also remember that that differential reinforcement doesn't mean just on and off. Think about it instead as a dial, where we're dialing up the magnitude of or the potency of our attention of the reinforcement based on appropriate behavior, and then dialing it down based on inappropriate behavior. We don't want to think in a binary way. Instead, we want to think that there's a range of behaviors that an individual can engage in, that there's what we might call precursor behaviors that are happening before aggression is occurring, right? That our child's starting to demonstrate some early signs of dysregulation. Perhaps they're whining or even huffing, right? Behaviors that you wouldn't necessarily think of as being inherently problematic for a young child, but you can start that differential dial right at the onset of those smaller behaviors to start to teach the child that there's an outcome to their choices even before aggression occurs. So thinking about this as a really proactive approach rather than just how do I manage reactive responding, that really helps parents plan ahead and feel like they're not going to be in a state of management as a result of this intervention.
Yeah, I love that. And I was thinking a lot about going back to Juliana's question about how you deal with aggression without timeout, and that the gradual approach does help with the reactivity piece. But I also think about times when timeout is just not feasible, and maybe not yeah, like I'm thinking of in public situations, or yeah, and out in the community. And I think that that families are dealing with aggression without timeout, outside of timeout. And so it is, I think, in our best interest to help families navigate that. And I remember when I was training in Matt's clinic, one of the biggest lessons I learned was you don't have to get hit. And I was like, oh, I didn't know that. I could step out of the room, or like a parent could go into a bathroom, or that they don't have to like stay there in that moment and get hit. And I think there are ways to kind of teach a parent how to deal with aggression in a very kind of artificial clinic space, getting a lot of practice with that, and then rolling it out and generalizing to the home environment. Matt, Diane asked a question: how do you discuss timeouts with parents who have read that timeouts are harmful? Do you recommend the parent removing themselves from the room when the child refuses to go?
Well, as a behavior analyst, I'm well equipped with dealing with families who've read things about my science that are untrue or exaggerated. So I connect with this idea. The preponderance of evidence suggests that when timeouts are done consistently, predictably, and proportionately, they are not harmful. And so what's hard is that that oftentimes parents are consuming things that are untrue. However, I will also say that timeout, when done correctly, is a punishment procedure, and we want to be careful about when and how we recommend punishment, because we know that reinforcement tends to be much more acceptable, promotes less reactivity, and clearly from the responses, the questions here, a lot of the concern is around what do I do with a reactive patient? And remember that this reactivity may be the result of a punishment procedure. We know that punishment promotes reactivity. So one option is to not include punishment in the service of minimizing reactivity. I also want to highlight this idea of Raquel's, which is, it sounds like we're talking about exposure. And if I had like a dinger, that would be I wish I did. That would be what I would push the dinger for. This is habituation, right? We want to think about this work in the same way that we think about anxiety work, in that our kids, by and large, are contacting something aversive, whether it's a restriction to a parent, or an unavailable parent, whether a toy becomes unavailable, whether a demand is placed that they don't want. Those are things that are aversive. And so how do we teach kids to tolerate things that are aversive? By very gradually exposing them to things, supporting them, letting them know that they can do it, minimizing accommodation in the presence of that contact with the aversive situation, and then rewarding the heck out of their efforts. And so this is very similar to the work that we do, and you wouldn't imagine that that exposure for anxiety that you'd include a timeout for that work, right? Because for some reason we've sort of feel like we treat anxiety a little bit differently than we treat other problem behavior. But if we think about it functionally, we're really talking about the same thing.
Yeah, and it's interesting because as a clinician, I've been met with resistance for timeout. And then when it came time for in my own kids' therapy that I had to do timeout for something, I felt a little resistant. And I was like, I don't know if this seems like an appropriate consequence for the thing that we're targeting. And I think one thing that's very helpful in this approach is that question of what skills are we teaching the child? And I think sometimes when I do more behavioral parent training, I actually don't know that I'm teaching the child anything apart from what they're learning through the experience of timeout. And I think teaching a child, like somebody mentioned in the chat, like what safe hands, what that looks like, and practicing that in the context of the absence of problem behavior is very potent. And I think that can increase parent buy-in. That are you certain he understands what safe hands is? So am I, and then kind of being able to move forward that way, I think is something that maybe we haven't thought much about for those that do a lot of work with the parent and teaching of parent skills. Oh yes, Corey's plugging her timeout book. It in that sentence, it looks like I also wrote it, but I didn't. I had nothing to do with that amazing book. But yes, it's definitely worth a read. Cheryl McNeil and Corey do a full expose on timeout, and provide a very strong argument for the use of it.
And I will jump in here since we're almost out of time, but yes, to that question, like my ears are burning. I'm like, I got to jump on this, but I agree with you 100%, Matt, that there is no evidence that timeout harms kids. And so there's evidence that yelling and physical methods hurt kids. So timeout is a great solution. But like you said, Robin, it's not always going to be the end all be all solution. So I want to take a minute to thank you guys both for being here. It was a fascinating talk. It's always good to get back in touch with the behavioral roots of what we're doing. And I think that's the mark of a really good clinician who can take an evidence-based, maybe sometimes manualized treatment and then tailor it to fit things based on behavioral underpinnings of what the evidence-based treatments are based on in the first place. So that was very relatable for me, and just love to get to hear your perspective on things. And really, really appreciate your time putting this talk together and being with us today.
Thank you all so much. This was a lot of fun.
Thank you so much.
Right. Have a great rest.